Welcome to Seniority Authority, the podcast where I track down experts to answer your questions on aging. I'm your host, Kathleen Toomey. Let's get smarter about growing older. In the famous words of Betty Davis, growing old is not for sissies, especially when it comes to our health. And often as we age, we can make inaccurate assumptions about health issues. So how can we educate ourselves? First, to identify the signs and symptoms and not to jump to conclusions. That's what psychiatrist Dr. Sarah Slocum is going to help us understand today. She's going to talk about what often gets confused, the difference between dementia, delirium, and depression in older adults. Dr. Slocum, who is a native of West Virginia, is a graduate of MIT and the Joan C. Edwards School of Medicine at Marshall University. She completed her internship at Dartmouth Hitchcock Medical Center and her psychiatric residency at the Medical College of Wisconsin in Milwaukee. She's board certified in both psychiatry and consultation liaison psychiatry and is currently physician lead of the psychiatric service line at Exeter Hospital. Thanks to our show sponsor, the Riverwoods Group, Northern New England's largest family of not-for-profit continuing care retirement communities, where independent, active adults find purpose, community, and peace of mind. Visit us at riverwoodsgroup.org. Now, let's hear from today's guest. Dr. Slocum, I'm so glad to have you on the program today to talk about this really important issue.
Thank you.
You gave a very fascinating lecture at Riverwoods, where I work, and I thought more people would benefit from hearing what you're explaining, just to help them know what to look for, because I think with some adults, it can be very hard to identify certain conditions. But first, let's start by asking what led you to the field of psychiatry and your interest in the older adult population.
Yeah, so it's a little bit of a roundabout answer. When I was a little kid, I always wanted to be a physician. And initially, I thought I wanted to do cardiac surgery. That's kind of what I had my dream set on. When I got to medical school, though, it quickly became apparent that I am not a surgeon and do not belong in an operating room. So I shifted gears a little bit. I thought that I would do maybe obstetrics or even pathology. And then I hit my psychiatry rotation and just totally fell in love with it. I had an excellent mentor that I worked with in medical school, and he was a consult and inpatient psychiatrist. And I enjoyed every day of it and immediately kind of decided to make the switch.
Now, that is really fascinating. And I, for one, am incredibly grateful that you are a psychiatrist in the hospital, because my family has worked very closely with you and you've been just brilliant addition. It's fairly new to have a psychiatrist on staff at a hospital. Is that correct? Or is that a typical practice?
So it just depends. I'm specifically a consultation liaison psychiatrist or a consult psychiatrist. And it's been a board certified fellowship for more than 10 years now, but that's not a ton of time. And it's really the area of psychiatry that focuses on treating patients who are in the medical hospital. So they either have a psychiatric illness because of their medical illness, or we're managing people who have a lot of medical problems who also happen to have a psychiatric illness. And I think that's where my interest in the older adult population comes into play, is because older adults are more likely to be hospitalized. They're more likely to have chronic conditions. And so my interest in geriatrics, it really comes from that consult psychiatry background. It's relatively rare to have a consult psychiatrist in a community hospital like Exeter. It's hopefully going to be a more common practice as the years go by, because I think we can add a lot of value to a care team.
I completely agree. And just as you pointed out, more older adults have multiple conditions, and the medications can interact and symptoms can be confusing. So as more and more people get older and are spending time at the hospital, it's really important to understand exactly what they're going through and not kind of jump to conclusions.
Yeah.
So let's talk about why there is confusion around these three different conditions, and what are the symptoms that someone might notice of either depression or delirium or dementia, because I think they can be often confused.
They can be. And that's because to some degree they overlap. So I'll start off with delirium. Delirium is what we really think of as an acute change in someone's mental status. And it usually means that they're not quite as alert or quite as interactive as they are normally. So if we think about this and let's think about this in a patient who maybe they live at home and someone's coming to check in on them a few times a week. They're still living independently. So it could look like they're just tired that day. They're just not not getting up, not getting out of bed, not doing what they usually do. Or it could look like them being overly sleepy, not really interacting like they normally would. And you can imagine that if someone has depression, you may see that same kind of symptom, right? They may not want to get up and go and get out and do the things that they normally like to do. Depending on how often someone's seeing them and how well that person knows them, those conditions could look exactly the same on any given Monday, right?
Sure.
Dementia is a little different because usually the decline happens over a long period of time and people kind of lose their ability to maybe remember things or their executive function, their ability to kind of keep up with tasks. And that's usually noticed by a family member or a close friend kind of in retrospect. So they're looking back and they're saying, well, my mom used to be able to manage all of her own medications and go to the grocery store, but we've noticed over the past 6 months, now we're managing her medications. So dementia there is a bit different and its symptoms can come across as different. But I would say that overall, the things to pay attention to are anytime someone seems different than their baseline. So if they are not interacting, if they're not able to remember things that they usually would be able to, if their mood is significantly off, then that should kind of prompt some other questions and maybe some more evaluation of how that person is doing.
So if you have someone who has these symptoms, is there a typical level that you would go to define and cancel out one condition over another? What would you default to first?
So it depends a little bit on where this patient is. I mean, obviously, I work in an inpatient medical hospital. So delirium is always going to be the one that I'm thinking about first because it's just the most common. I think in the community setting, when you're thinking about yourself or your friends or your loved ones, I think a general awareness of all three of them is important. And really, we think about timeline to help delineate between the two. So like I said, dementia is not a quick disease. You're talking about a disease that frequently starts slowly and it progresses over years. So someone's change from last week to this week is not going to be significant. Depression is a little more variable. Certainly someone can have an episode of depression that comes on, and it can come on over a few days or over a few weeks, but it's usually something that's happened to that person before. We do have some patients who have what we consider like a late onset depression. So they may not start having depressive episodes until they're in their 60s, 70s, in some cases even later, but that's pretty rare. Usually patients who have depression have had depression their whole lives or for a long period of time. So often they are able to say, or their loved ones are able to say, oh, this looks like when dad was depressed 5 years ago, and they can work off of that and those symptoms. Delirium is different there. So it's very quick. This is something where someone would say, okay, last week, mom was totally in her normal state of health. We talked just like we normally do. This week, she can't hold a conversation. She's super sleepy. That change is rapid. And it can even be, if you're watching someone in the hospital, like you can watch it happen over a few hours, which is significant. So that kind of tie into time is important. And they need different levels of care. They need different interventions. So it is important to know which one is which.
That's great because that leads to my next question, which is how prevalent is delirium among older adults? Is this something I think many of our listeners understand that dementia comes on over a long period of time? It can be, you should go to a neurologist to really get a test to see if it's something more significant than typical age-related memory loss. But delirium, I think it's something that we don't necessarily think of when we think of older adults.
Yeah. So let me give an example of delirium or an analogy for delirium first. When I think of delirium, I think of it as a symptom. I don't really think of it as a standalone diagnosis, although technically it is. But I treat it like I treat a fever. So if you have a fever, something is causing that fever, right? It might be an infection, it might be something else, but there's something driving it. And in order to really get the fever to go away, you usually have to address what is underlying it, whether that's an infection, whether it's letting the virus run its course, whatever it may be. Delirium is the same thing. So delirium is being caused by something, usually medical, rarely kind of psychiatric causes. And in order to get the delirium to go away, you have to figure out what's causing it, and then address that underlying driver. So it's important to know that. And that comes into play with kind of how prevalent it is. So it's always more prevalent in patients who are older, who have a history of dementia, and then who have any type of chronic medical problem. So things like heart failure, cancer, lung disease, those types of things all predispose you to having delirium. Usually it's like an equation. It's like an addition problem. Someone is maybe they're 75 and they have a little bit of a mild cognitive impairment and they have high blood pressure, and then they get an infection. And that's like the straw that breaks the camel's back. Then they become delirious, that like acute altered mental status change. And then you have to address the infection or kind of whatever the most recent thing is that tipped them over the edge in order for them to get better. So what we see is that about 20% or so of emergency department patients are delirious.
Wow. It's 20% of emergency.
Just wait.
Okay.
Just wait. It's going to get so much higher.
All right. Okay.
So 20% of emergency patients, if you look at elderly hospitalized patients, then you're actually looking at up to 40%. It's almost 1 in 2.
Wow. Right? 40% of older adults who are admitted to the hospital are experiencing delirium.
Whew. Do you want to take a guess at what it is for elderly patients in the ICU, the intensive care unit?
Let's say 60%?
75.
Oh my gosh. 75% of older adults in the ICU are experiencing delirium. That's so high. That's
so high.
So it seems to me that delirium is kind of like the most prevalent front-facing medical symptom that has to be treated before anything else can be even touched.
Yes. And the tough thing is that it's so prevalent, we miss it. Like we forget about it, I think, because it's so prevalent that we don't necessarily do everything for it that we could be for any given patient.
Why would, if it's so prevalent, I would think then is it just that some people assume this person is older and they're out of it, quote unquote? Is that
so that's
kind of an ageist thing? Yeah.
A little bit. And there are 2 types of delirium. Well, 2 main types. You can have hyperactive delirium or hypoactive delirium. So hyperactive means that people are, maybe they're yelling, they may be agitated, they may be pulling in the hospital at their IV lines or things like that. In the community setting, they may be pulling at their Foley. They might be yelling out for staff to come help them. They may be just very confused and kind of not letting people get close to them.
So highly agitated.
Yeah. So those people get noticed because they're kind of causing a ruckus. We're going to notice them in the outpatient setting and in the inpatient setting. But the other part of delirium, the hypoactive or low activity people, they don't get noticed because they're not causing a ruckus. They're kind of quietly lying in bed. They're not as interactive as they would be. They're sleeping more than they would be. We just kind of say, oh, Mrs. Smith is really tired today. And we say we're going to let her rest, and then we move on. When in fact, we need to be saying, okay, is she delirious? Do we need to help figure out why? What treatment should we provide for that? Because it makes a difference.
Sure. And if you're in the hospital setting and you're not in a place where everyone knows you and you're older and you're very, very sleepy, I could see where people would say, oh, she's 89, 92 and tired, and we're just going to let her rest. I could really see that. Thank you for explaining that. That's challenging. Now, how serious is delirium?
So it's serious. I'm a little biased, right?
Yeah.
But I think it's serious for a number of reasons. Number one, it actually increases your risk of having delirium again. So once you have it once, you're at higher risk of having it again. And it increases your mortality rate. So patients who have delirium have almost double the chance of death over a given period of time as a non-delirious patient. So if you come in for whatever, for your urinary tract infection, and you have delirium, you're twice as likely to end up having a fatal outcome from that as someone who doesn't get delirium. So that's huge, right? Double the risk of death. It also, for patients who are living in the community and living independently, it almost doubles their risk of needing to discharge to a long-term care facility or to some other type of living environment. So it really can change those huge decisions and can take away someone's independence.
Wow. That is very, very impactful. If our audience is listening to this and they want to understand how they can help physicians or others diagnose the difference between delirium, if they have a concern about this, especially if they're, as you said, hypoactive, so they're being more sedentary, sleeping, etc., they're not hyperactive, they're not obviously delirious, what would you suggest they look for or do?
I think the best thing that family members can do is provide information to the care team about what someone's baseline is. So if your loved one is usually someone who is getting up in the morning and having breakfast and taking a short walk or participating in some type of programming, that kind of thing, or maybe they have a part-time job, giving that information to the care team when they're in the emergency department or in the hospital is really important. Because like you said, we see someone in the moment and we're saying, probably because of some bias and some ageism, et cetera, we're saying, oh, this person's 80. Great, let's let them nap. They probably do this every day. Mm-hmm. When in fact, that patient may be someone who is out on the nature trails at PEA in the morning, and that's really not their baseline at all. So giving the baseline to the providers help us figure out how different is this person when we're seeing them from how they are on any given day. I think the other things to kind of just look for are what we've talked about, kind of that change in functioning, the change in awareness and alertness that can kind of clue you into they're just not acting the way that they normally would.
So just be aware of changes of behavior and be more conscientious with an older adult that this could occur.
Yes.
If you're getting smarter, let us know. Leave us a review or rating wherever you listen to podcasts. Tell your friends and follow us on social. We're at Seniority Authority on Facebook, Twitter, Instagram, TikTok, and YouTube. And don't forget, if you're listening to YouTube, hit the notification bell so you can subscribe. Or subscribe to our newsletter at seniorityauthority.org so you don't miss a thing. How do you treat delirium? And you already mentioned that it does recur if you have it once. the chance is strong it'll come back again. How do you treat it?
Yeah. So we have to first and foremost figure out what's causing it, right? Like I said, a whole bunch of things increase the risk of delirium. It's really almost everything you can think of in the medical realm. I hate to be so broad, but it is. So things like someone's age, their existing medical problems, kind of your problem list, if you will. Just about everything on that can contribute to delirium. Medications can contribute to delirium. So especially ones like benzodiazepines, opioid pain medications, things that we consider anticholinergics, which is like Benadryl. Some other medications have that property as well, but Benadryl is a big offender. Those types of medications can contribute to delirium or increase the risks that someone is going to have delirium. And then we run the gamut of kind of more acute medical things like infection, strokes, head injuries, like I said, cancer. If someone has cancer or they have an acute worsening of their cancer, that can predispose them to delirium. So first we have to figure out why they're delirious. Then the first step in treating that is addressing that underlying cause as best we can. Sometimes you can't reverse a cause entirely, but managing it to the best of our abilities is important. The next step in delirium management is really conservative. So when I talk about conservative delirium management in the hospital, I'm talking about making sure that someone has their eyeglasses, their dentures, and their hearing aids so that they can actually sense what's around them.
That's
we forget
really
about that.
important. Yes.
Yeah.
Because if you are someone who needs hearing aids and you're in the hospital without them, then people will think you are cognitively not quite there because you're not communicating effectively.
Exactly. And like I said before, sometimes we're not great at making sure they're in someone's ears, even if the hearing aids are here in the hospital, or making sure that they're charged. We do try to do a good job of that, but sometimes that gets missed. The other elements of conservative management are really trying to align someone to a normal sleep-wake cycle, which means that in the morning, we need to be opening someone's blinds, turning on the lights, kind of exposing them to ambient noise, helping them wake up naturally, hopefully. And then at nighttime, helping them turn off their television, turning off lights that are maybe available in the room, trying to keep the environment quiet, and shutting their blinds, etc. So really changing the light to match what it is in the regular world at that point in time. And that comes along with kind of not letting people nap all day. Because what can happen is they nap all day, then they don't sleep at night, and then we get stuck in this cycle. We call it a day-night reversal. So the patient's days and nights get flipped. That can be really hard to recover from once it's happened. As you can imagine, all the important stuff in a hospital happens during the day.
Oh, sure.
Yeah. So if you're napping all day, physical and occupational therapy can't really meet with you. You may not really be awake enough to hear what the doctor's telling you about the plan. So then when someone asks you later, hey, what's the plan for today? Did they make any med changes? That patient's not going to remember.
Yeah. And it is then hard to get back to a regular cycle.
Yes.
So I like that. That's conservative. That's understanding kind of where you are and getting all the things that you need, which for some people is just an automatic. But if you're sick and you're not your best self and you're at the hospital, it's easy to lose track of that.
Yeah. There's another really important thing that family members can do to help with delirium management, and that is to bring in something familiar from home. So whether that is a blanket or maybe like a sweater or something that a patient particularly likes, bringing in a photo. They make those great like plexiglass frames that you can get cheaply. Something that's easy to kind of wipe down. It's not going to break while it's here in the hospital. But putting just a nice like family photo in one of those frames and bringing it in and leaving it at someone's bedside can just make such a huge difference because it reminds the patient of who their family is and that they're loved and all of that. It also serves as kind of an engagement point for staff. So if I go into someone's room and I see a family photo or a photo of a pet, it's really easy for me then to ask my patient, hey, who is this? Or is that your cat? That kind of thing. And that helps cue the patient back to remembering those things and then helps build that bond with their providers, their nurses, their doctors, et cetera. So that's
a
really
great
important.
idea. It orients them to, okay,
Yes.
This is my family. This is my pet. And they have something else to talk about besides themselves and their symptoms.
Yes.
Oh, I love that. That's a great suggestion.
Yeah. So that's conservative delirium management. So find the cause, use conservative management. And then there are times that we use medications directly to treat delirium, but it's usually reserved for those patients who have the hyperactive delirium. So the ones who are maybe agitated, they might be trying to remove their IV line or something like that. And sometimes we do have to use some sedating medications to help keep those patients calm, especially if that means that we can then get them treatment for what the underlying thing is. So if you have an infection and you need, let's say, IV or intravenous antibiotics, we can't get that into you if you don't have an IV in place. So letting us kind of use medications to facilitate the other forms of treatment is something that we do end up doing at times. I talk to a lot of families and it really throws them for a loop when they hear that a psychiatrist wants to start their loved one on an antipsychotic, right?
Mm-hmm.
Immediately that family is thinking, well, mom or dad doesn't have any type of psychotic illness. Why are we using this medicine? It's also a medication class that has some potential side effects. There's actually a black box warning on the antipsychotics for older adults from the Food and Drug Administration because there's a small but increased risk of sudden death. That's freaky, right? When you hear that we want to use a medication that has a warning on it to treat your loved one, that can be scary.
And it's very scary if your loved one has never had any mental health issue and suddenly they're being treated with an antipsychotic that is very frightening. And I think, many people are careful about how many medications they give older adults, rightly so, because sometimes too many medications can interact with each other. But it sounds like this is for an acute reason, for a specific reason to control a limited behavior to help. So this makes sense.
It makes sense to me, but again, I have a bit of a bias. And I think, though, that families having an awareness of it and still checking in on, hey, does mom still need to be on this medication? Has she been requiring it at the hospital? What's the plan for weaning it and tapering it? That can be a great reminder to us physicians to say, oh, we actually do need to work on a taper schedule for this medication, or we need to make sure that they're off of this medication before they return to their home. It's a good reminder. So I would always encourage family members to be diligent about asking those questions.
Well, I have a question, which I know there's probably no straight answer for, but if you're treating, you've done the conservative management, and then you've layered on an antipsychotic, about how long does it take for the delirium to clear? And I'm sure it depends your age, and if it comes on quickly, is this something that can be treated swiftly?
That's a great question. So sometimes it can be treated very swiftly, especially if you have someone who doesn't have a lot of those risk factors. You can actually have delirium in kids. That's pretty surprising too.
Yeah.
But kids tend to bounce back really quickly. Just like kids, if they get a cut, they heal very quickly, right?
Mm-hmm.
The same analogy applies. So the more risk factors that someone has, or the longer that they've been delirious, the harder it is going to be to get them to be not delirious again. Okay. What I like to say is you have to, in older adults, this is kind of my rule of thumb for older adults. You have to treat the underlying condition or stabilize it. And then I like to give people another 5 days or so before I really expect them to be back at their baseline. So if your mom is 80 and she got a urinary tract infection, she got delirious, and they give her a 5-day course of antibiotics, I like to say that we're going to start seeing some improvement over those first few days as the antibiotics kick in and the infection goes down. But I wouldn't expect her to be back to normal until the antibiotics are done at day 5. And then we give her some wiggle room, some leeway over the next several days. Some of that is because a lot of our medications, like antibiotics, they continue to work even after kind of the acute prescription phase is done. And some of that is because it just takes your body some time to bounce back and to heal.
Sure, because you're fighting this infection full time. And so
Yes.
it's not going to be quick necessarily.
Right. And there are different causes, right? Not all delirium is from an infection. So if you think about someone with heart failure or COPD, once they are treated through that exacerbation, same thing. The time to treat the exacerbation and then give them another 3 to 5 days if they're older to really see where they're going to land. Not all patients who get delirious get totally back to their baseline, which is another struggle. So sometimes an episode of delirium really is kind of a step down on how they're thinking and how they're functioning. But you should be able to get a relatively good sense of where someone is going to be, what their baseline may be around that 5-day mark after you've kind of completed treatment or stabilization.
Okay. For the audience, what can they do to prevent the incidence of delirium? Is there anything that is like a lifestyle change that can decrease the chance of this occurring? We're very preventative minded here at Seniority Authority. So is there anything that we could do to reduce this happening?
I love it. So there is. That's the great news. So
Good.
making sure that you or your loved ones are kind of only on the medications that you need to be on, and kind of being diligent about if you don't really need to be on a medication, making sure that you're not taking things just to take them. Okay. Similarly, making sure that you're getting a lot of exercise or as much exercise as you can tolerate is always going to be helpful, because that is going to improve both your physical health and your mental health and kind of make you more resilient when those additional stressors come. So those are my 2 biggest things: is keep an eye on your medication list, take what you need to, but don't take stuff that you don't really need to, and make sure that you're getting exercise. I think the other things that we can do are to kind of try to manage those chronic conditions as best you can. So for instance, if you have diabetes, making sure you're following a recommended diet, things like that, whatever the kind of underlying management for those chronic conditions is important.
So it sounds like you really have to pay attention to those baseline issues that you have, because they can be exacerbated, and maybe you got by with not paying attention to diabetes for years, but now it's really going to affect you significantly if you don't.
Yes.
When you say, just a curious question, when you say don't take too many medications, are you also including supplements? Because so many people are taking various supplements and this, that. I'm not asking you to say yes or no, but are you throwing the additional supplements into the list of things you shouldn't take unless you really need them?
Yeah, it depends a little bit on the supplement. So things like folate, vitamin B12, vitamin D, those are pretty harmless things. You can take a lot of those and be just fine. There are some supplements that if you take them, they can interact with your other medications. So St. John's wort is a big one within the field of psychiatry. Because of the way that it is broken down in the body, it can actually change how your other medications are broken down. And that can be a problem, right? So you can imagine that if you're taking St. John's wort and your doctor doesn't know, or even sometimes if they do know, but you get started on a certain dose of a blood pressure medicine, right?
Mm-hmm.
The St. John's wort might mean that is not broken down like it normally is. So your body sees or experiences a higher dose than intended. then your blood pressure
Wow.
gets low, that can be a struggle. So there are certain supplements that are not harmless. The other big ones in that category are things like diet pills, like
Oh,
supplements
sure.
to help with weight management. Those can
Hmm.
be dangerous sometimes, as well as there are some that are marketed as like hormone supplements. As always, talk to your primary care physician and see if you can dig into exactly what's in those. But those can be problematic for some people too. But regular run of the mill, vitamin E, vitamin D, those types of things are pretty harmless.
Okay, good. Thank you for clarifying. So I think you may have already said this, but just one of my last questions is there one piece of advice you would give to older adults or those caring for older adults to either stop or start doing today to improve their mental health?
Exercise will always kind of be my number one recommendation there for caregivers and for patients. Exercise has actually been shown to be just as good as medicine at treating depression.
Wow.
Yeah.
Wow, that's terrific.
It is. In the studies, there are some caveats to that, right? Like they looked at aerobic exercise. Not all of my patients, not all of your listeners are going to be able to go out there and go running or walk quickly or kind of meet the official bounds of aerobic activity. That doesn't really matter so much. Getting some type of intentional movement in is what's important. And it helps your brain and it helps your body. So that will always be my number one recommendation. I think the other thing is to kind of find your passion, find your hobby that brings you joy, that kind of helps you light up, and keep at it. Don't give it up. Make it a priority. If you like to go golfing, you like to play tennis, you like to read, whatever is your thing, stick with it, even as you have maybe some barriers to getting it done.
That is fabulous, fabulous advice because we have talked on this podcast in a number of different episodes about the importance of finding a reason to get up in the morning.
Yes.
You know, even if you're at the point where your career is over your official people pay me career and you've raised your family, there is still a reason for you to be here. And you just need to unlock that, and that will help. And then your advice on exercise, we've recorded over 60 podcasts over 2 years, and this is what everyone is saying, that it is so important. So for those of my listeners who are really hesitating about this, please start where you are and find a way to move every day. It's going to really pay you back in your quality and of life and a longer life, hopefully.
Yes. And you bounce back more quickly too.
Yeah, exactly.
Yeah.
All right. Well, we already know you're a very smart and caring doctor. And now we're going to get to know you a little bit more with our Fast Five lightning round. So this is the time, Dr. Slocum, for you to share with us, what is your guilty pleasure?
Ice cream, hands down.
Okay. What's your favorite place in town to get ice cream?
Oh man, I end up at Stillwell's usually because I have kiddos and it's just very convenient, but I've tried Charlie's too, and it's also delicious.
Yeah. And that's adult ice cream, which I need to try that.
Yeah.
What's your favorite healthy practice?
I like to run. So I have kind of picked that up as after high school. I actually just got into the lottery for the New York City Marathon this fall.
Oh my gosh. Congratulations.
Yeah, thank
you. Will this be your first marathon?
It will be my 10th.
Wow. Oh my gosh. That's impressive. It's quite a race. I've been on the sidelines of it. So is this your first New York City marathon?
It'll be my first New York City. Yes. And I've just heard that it's amazing, that it's just 26 miles of total cheering and awesome crowd support. So I'm excited to see what that's like.
That is wonderful. Wonderful. What's guaranteed to make you laugh?
So I actually asked my kids this last night, and one of them said tickling me. I guess I'm pretty ticklish. The other one said dad jokes. So I
Dad
guess I
jokes.
really like puns. I don't know. That's what they said, and I think they're right.
Okay. All right. What's the last book you loved?
So I'm a huge reader. I love to read. It's probably my passion thing. I think the last one that I read that I loved was probably Lessons in Chemistry by
Yes.
Garmis. So
Yes.
it's pretty new.
It's a fabulous book, and they're turning it
Yeah.
into a TV series or a movie.
Oh, I didn't know that.
Yeah, I just saw that on social media. It's about a woman in a brilliant female scientist in the 1950s, right? Who's
Yeah.
thwarted from pursuing her real scientific career by the mores of the times and what she
Yes.
does instead. It's a terrific book.
Yes. I really, really enjoyed it.
I could see where you would. What's your favorite escape?
Oh, I think I like to be outside to escape. So whether it's a walk in the woods with my dogs or kayaking, I don't get to do that as much as I would like to do it, but that's definitely something that brings me joy, recenters me, helps me refocus. New Hampshire is a great place for that. We have some wonderful access to the outdoors.
Yeah, we are very lucky. We have the beach, the mountains, the woods. Yeah. And being outside, I think, is wonderful. Thank you so much, Dr. Slocum, for sharing all your knowledge. I think this episode really will help people understand how to differentiate between depression, delirium, and dementia, and really help them stay more alert to what those signs of delirium are and how to address it. So you've really provided a great service to our audience. Thank you.
Thank you for letting me come on and talk about it. I appreciate it.
That's been great. That's our show for today. If it helped you think differently, will you help me? Go to the Seniority Authority page on your podcasting app and hit either the plus, heart, favorite, or subscribe buttons so you don't miss out. And tell your friends so we can reach more minds. Until then, enjoy the chance to get smarter about growing older. That's our show for today. If you liked it, please tell your friends so we can reach more minds and keep the conversation going. Or follow us on social at Seniority Authority. I'm Kathleen Toomey. Until next time, enjoy your chance to get smarter about growing older.